So the first thing I would like to do is to invite our first speaker to come and join us. David Lawson, known for many years, has spent quite a part of his career as Chief Procurement Officer of Guy's and Tommy's, and he's the one guy that always managed to unlock money from very big pots of money from the system, and we never understood to do it. Now, of course, he's at the Department of Health and controls the big pots of money. So it's quite interesting to see whether Guy's and Tommy's get as much as they used to. But David has been here, a good friend of GS1 Standards and a supporter of us for many years. In his new role of MedTech strategy, he's actually really brought a healthcare provider organization view to the center. And he's come along today to share some of his thoughts and progress of national programs. So without further ado, may I welcome to the stage David Lawson.
So yeah, it's great to be here. So my role is now kind of policy lead for medical technology, and a key part of that is to try and look at data, and in particular medical device data. So I've got a few slides at the beginning just to kind of probably paint a picture that you all recognize anyway, but I thought I'd just kind of reinforce the point. So this slide is from one of the largest medical device companies that supplies into the NHS at the moment. I haven't given the name to kind of protect the innocent, but this company receives about 250,000 purchase orders every year. And if you look at this chart, which is looking back over the last 12 months, what it shows is that despite all the investment in kind of EDI interfaces, catalog management systems, and so forth, you've still got a relatively high percentage of purchase orders that can't be processed first time because either the price is wrong or the product data, the product code is incorrect. So this creates what I describe as kind of friction in the process. So that medical device company, as with pretty much all other medical device companies, have to employ additional people to kind of rework and administer that process. And then from a hospital perspective, it also means delay. So when a purchase order is raised, if there's an error, the supplier will not process it until that error is corrected. So we have an issue around process friction because of data quality issues in terms of medical device data in the supply chain. This is another view. So Advising, you'll know well, I think they're definitely here today. I've seen a kind of orange glow in one of the corners, which is always a sign that Advising are in the building. Advising have been looking at data pretty much. They were appointed after the Carter report to create the national price benchmarking tool, and they've been pretty much leading the way in terms of analysis ever since. I asked them to give me their worst slide illustrating the challenge with product information. So they gave me a STEM, an orthopedic product. So in this example, in terms of the data set that they see across the NHS trusts are calling that product code, that product, 150 different ways. And actually, that particular product has 30 different sizes. So the total number of descriptions used for that one product is about 700. So we have an issue about data quality not working through the supply chain. From next month, are we in May now? Is it May today? 1st of May? Tomorrow. So 4 weeks' time, 5 weeks' time, from June, new post-market surveillance regulations come into force, where it's a legal requirement for all medical device companies, when they're placing products into the UK market, to have a UDI. So from a post-market surveillance perspective, that's obviously important. But if our systems through the supply chain are not keeping that UDI, then it creates a problem in terms of how do you track when there's incidents, how do you monitor the performance of products if you can't see where that product is across that supply chain. So this is not just an issue around kind of basic efficiency, process efficiency, it's also an issue in terms of patient safety, in terms of that creating a robust post-market surveillance regime. The other part of my work is very much around innovation adoption, huge push around trying to encourage better adoption of the most effective technology. You'll see this come out in Life Science Sector Plan, 10-year plan over the coming months. We're very good in the NHS in terms of innovation, not so good in terms of access and uptake and adopting innovation at scale. If we don't get post-market surveillance right, then from a regulator point of view, it's going to be very hard for the regulator to take more of a risk-proportionate approach around new and novel innovation. So this issue about data and keeping that UDI throughout the supply chain is not just important in terms of patient safety, it's also quite important in terms of innovation adoption, if we want to try and push a more risk-proportionate approach for new, novel innovation as well. I think everyone knows this anyway, but I wanted to kind of just reinforce why this stuff is important. I guess the other point I'd say is none of this is new. So way back in 2007, you had the Coding for Success report, talked about GS1, talked about barcoding, talked about standardization. You then had the 2014 e-procurement strategy by John Warrington, talked about having a national PIM. And now, 2023, up to date, the department launched the MedTech strategy, which talks about the importance of data infrastructure. If I was being controversial, you could say that the only substantive change that's happened in the last 20 years is the logo on those 3 reports. But I can't say that because I'm a civil servant. So, but you could take that view. So we need to do something about it. What we're trying to do now is deliver a national PIM and basically try and improve the position where you've got data providers and data consumers. At the moment, it's not quite working. It's a mismatch, and you've seen that with the kind of first couple of slides. So the basic principle is if you have a national PIM, you create a single version of truth. And that's what we're trying to do at the moment. So we spent probably about a year and a half trying to work out what does that actually mean in practice and create design principles. And my colleague Jasleen yesterday kind of talked about this in more detail, but essentially it's about bringing together the different data sources into one place to create that single version of truth. And GS1 is linked to that, so you've got the GDSN, but you've also got the MEDEV-VIS, you've got the EUMED, lots of complicated acronyms, but the basic principle is we create a single version of truth. We create a system that is able to be updated and is dynamic and has feedback mechanisms. And then that single version of truth is then used by the consumers of that data. And that's the kind of design principles that we're working on. In terms of timetable, so we've been going through quite a structured process. So when you create a national digital tool, we have a discovery phase where we kind of confirm that this is a problem to solve. Once that's been confirmed, you go through what's called an alpha phase, where you understand and work out what's the design principles and you test different concepts. And then you go into beta, where you build the system. So we're now about to start the beta phase. We launched a procurement about three or 4 weeks ago. We're due to award a contract to the supplier by the end of May, and that supplier will build the beta. The first part will be to build a private version of the beta, and if there's any trust or any suppliers in the room who want to get involved, we would like you to be involved in that private beta phase. So if people do want to get involved, please reach out, and we'd like different parts of the system to be involved in that private beta to make sure that when we go into public beta from January, where this system is essentially launched, that the system is as robust as possible. My view is that this system will have to be mandated. If suppliers are now mandated through regulation to provide UDI, we have to mandate that this system is in place across the supply chain. Otherwise, we will not achieve a robust post-market surveillance regime that's important for patient safety and important for innovation adoption. So in terms of mandation, my view is it should be mandated. Now, we will not mandate it in January. We will give it time to make sure it's robust. But ultimately, this system has to be mandated in order to provide that clean data throughout the supply chain. So public beta by January next year, so that's 9 months away. What this then enables is also other initiatives. So I think NHS supply chain, maybe I think presented yesterday in terms of NETIS. This is National Equipment Information Tracking System. They've already got about 600,000 assets in that tool. By April next year, they're aiming through interfaces into trust EBME systems to expand that to 2 million and provide effectively total visibility over equipment assets. So a very powerful tool to inform decision-making going forward. The PIM will help enable that system to be fully utilized and hopefully design out some of the issues that advising have had on kind of price benchmarking by improving data quality. And when I've spoken to the NETIS team, they've had to spend a lot of time in their existing data cleaning it up because of the issue in terms of different products, the same product being called so many different descriptions. So the PIM will help enable and support that NETIS project. The other project we're working kind of behind PIM is also, at the moment, we call it the Compass. And essentially the principle there is to support trust local decision makers make informed decisions around medical devices by providing greater visibility of what devices are available by each category. So providing a side-by-side comparison tool of a category, drawing together available information on the products. And that, again, being a dynamic system, the PIM provides the base infrastructure to enable that system to operate. And also, the other element of that system is also to have a passporting tool. So one of the frustrations from industry is the fact that they have to fill out the same forms to multiple trusts against the same national standards. So why can't we have a national repository, a national standard, and allow that to be passported to kind of streamline the process, speed up local decision-making? So that project is a quite early stage. We've just completed discovery phase last month. From June, we're starting the alpha phase to kind of test different design concepts. And again, one of the invitation for me is that if both people from the kind of procurement community and from industry, if they're interested in that potential of that system, if they want to get involved, then please reach out, because we want to get different ideas explored and tested through that alpha phase. And then next year, we'll aim to go into beta and then launch that system. So that's how some of the other initiatives that we're doing in terms of MedTech strategy kind of link together. But the PIM is key. The PIM is key to kind of get that data quality across the supply chain to enable these other initiatives to kind of fully operate and work. So final slide, I guess key messages. One, don't give Glenn your favorite song or any song. But the case for PIM is clear, and it has been for a long time. We will launch it within the next 9 months. And I think it's a key enabler. So a key enabler for lots of things, but particularly for me, in terms of my other key part of my role is around innovation adoption and things like the Compass. I need the PIM to enable things like the Compass to operate. But it's also fundamental in terms of patient safety, post-market surveillance. Thank you.
Thank you, David. We can take one quick question, if that's okay.
Hi, Frankie Wallace, Data Standards at NHS Supply Chain. I'm just interested to know, when you talked about mandating the PIM, is that for trusts and suppliers to use, or trusts and manufacturers of medical devices?
Well, MHRA is speaking next, but it's a legal requirement from June for suppliers to provide a UDI. So, and also to be more proactive in terms of post-market surveillance. So my sense is that the obligation is already quite clear for suppliers. The system, the health system, now needs to play its part in terms of the use of that data. I don't think any supplier here or outside the room will object to the principle of their UDI for their product being used in the supply chain.
Okay, Thank you.
Good. Thank you very much, David. Thank you.